I am now pleased to introduce our first speaker, Dr. Alexander Kallen, the Chief of the Prevention and Response Branch in the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention. Dr. Kallen is one of the authors of the recent CDC Vital Signs report on unusual resistance, and we're so grateful he's able to join us today to discuss this report and the CDC's containment strategy. Dr. Kallen?
Great, thanks very much. Hi, everyone. Great to be with you this afternoon. I'm just going to spend a few minutes talking about the new response to, or the new strategy to responding to these kind of unusual resistance phenotypes that are showing up more and more in the United States that was highlighted in the recent CDC Vital Signs. So I'd like to start with the story of what can happen if we are not aggressive about responding to these types of bacteria. And this paper, which came out in the year 2001, highlights a new form of resistance that was identified from an isolate collected in 1996 in North Carolina during a CDC project to look at resistance in intensive care units. And it was highly resistant to lots of different antimicrobials, and had so much resistance that it actually underwent some kind of special analysis to detect what was the mechanism behind it. And what they detected was a new carbapenemase. This is an enzyme that breaks down lots of different antibiotics, making them not effective. And this was the first time a carbapenemase was identified in the United States, and it continues to be the carbapenemase that's the biggest problem in the United States, and it is called KPC, or Klebsiella pneumoniae carbapenemase. This enzyme creates these bacteria that you've heard so much about called CRE, or carbapenem-resistant Enterobacteriaceae, that our former director, Dr. Frieden, coined the nightmare bacteria. So the next slide shows kind of what the picture looks like as far as reports to CDC of these bacteria, starting in 2001 when the report came out, and then 16 or 17 years later in 2017. And I think what you can see is kind of a slow but steady spread across the United States, starting in the East Coast, moving to the West Coast, and then kind of filling in the middle. And actually, today that map is completely filled in, even with Idaho reporting at least one case of KPC-producing CRE. And I think this illustrates what can happen when we use our kind of usual strategy to responding to antibiotic resistance, this kind of siloed approach that's been what has been employed in when most of these resistant bacteria have kind of emerged. In 2017, CDC rolled out a new strategy, which is being called Containment, and it's designed to address these emerging threats as were described at the opening, that are being found more commonly in the United States over the last few years. This Vital Signs report is an opportunity for different divisions in CDC to highlight some of the important topics that they're working on, and our division has done one a year for the last few years, and on such topics as central line-associated bloodstream infection prevention, antibiotic stewardship, and CRE, or carbapenem-resistant Enterobacteriaceae. This approach is really kind of based on a pretty simple idea, and that's that once antibiotic spreads and becomes common in the country, it's very hard to control, and it's much more efficient and effective to respond early when this resistance is first identified and before it can become common. The main points in this strategy is that makes it different from kind of the normal approach is that, first of all, it's designed to be based on, to be implemented with the detection of a single isolate. So historically, when these isolates are detected in healthcare settings, often, not much is done to look for other cases or to intervene other than the routine things that might normally be done when a resistance pathogen is detected, unless there's an outbreak or a cluster. And so this response is designed to act even at the presence of a single case. The other thing that's kind of interesting is historically when we look back at the way we've approached resistance, we've often approached based on what's called a phenotype, so an antibiotic susceptibility pattern. Many people, if you know methicillin-resistant Staph aureus or MRSA, or vancomycin-resistant Enterococcus, all important MDROs, but those were primarily based on a phenotype, a drug susceptibility pattern. But what we've learned over the years, especially with the gram-negative bacteria like CRE and Acinetobacter and Pseudomonas, is that often the underlying mechanism is also important. But we haven't historically had ways to delve down that deep to figure out what the mechanism is to be able to respond to these differentially. And so this response now enables us to do that. Some of the bacteria and fungi that are being targeted by this approach are shown on this slide and include the CRE that we've been talking about, but particularly the ones that produce a carbapenemase like KPC, which is what I mentioned at the beginning. Carbapenemase producing Acinetobacter and Pseudomonas. This new highly resistant yeast called Candida auris, and also pan-resistant strains, or strains of bacteria that are resistant to all known antibiotics that we have available to treat them, a fortunately very uncommon event here in the U.S. The containment strategy has 5 different pieces to it. The first, and perhaps most important, is to be able to detect these isolates when they appear. So without knowing that they're there, it's hard to respond. The second is infection control assessments led by health departments to actually make sure that the appropriate infection control practices are in place to prevent transmission. Colonization screenings, this is important because many of these bacteria only cause disease in a very small minority of people, but these other people who have the bacteria on their body without symptoms are called colonized, and these colonized patients can serve as a source of transmission as they are not usually recognized and the appropriate precautions are not put in place. The next is coordination between healthcare facilities. As I described the outbreak of CRE originally in the United States, the KPCs in the first few slides, that was using a very siloed approach where different facilities did their own thing, and this coordinated approach allows us to be more aggressive and work between facilities to help control the spread, and lastly, continued vigilance until the spread is controlled. In order to detect resistance, CDC has put in place a very exciting new program called the Antibiotic Resistance Laboratory Network. It has 2 pieces. One, it's state and local health departments that actually can do specialized testing to look for these specific mechanisms, and the second is the 7 regional labs across the country that actually can do testing for looking for these patients that might be colonized and not otherwise detected. In addition to that, CDC sponsors more than all or part of 500 different staff in state and local health departments across the United States that are working on these issues, as well as 35 programs in 35 different states or local health departments in order to address these problems locally, and a large number of projects via our Prevention Epicenters program to look for novel ways to prevent transmission of these pathogens. So just as highlighted in the MMWR that I mentioned, the vital signs, between January and September 2017, nearly 6,000 isolates were tested, and 25%, sorry for the typo there, 25% were actually these highly resistant carbapenemase-producing strains that wouldn't have been detected without this testing. As part of that, there were 70 responses, including almost 1,500 screening tests. 11% of screened patients were positive, and these again are people that probably wouldn't have been detected without this testing, and the appropriate precautions were able to be put in place. In addition, this has helped us identify higher risk facilities, healthcare facilities where amplification or greater spread is happening, to be able to target these facilities to slow transmission. Just to give you kind of an illustrated example of what a containment approach looks like, one that was highlighted in the MMWR, includes this one where the health department was notified of a patient who had one of these unusual resistant CRE, produced an enzyme called IMP, which is rarely seen in the United States. The health department went to the facility, assessed the infection control interventions, and actually did a survey of the patients, the contacts there, the residents that were contacts, and found 5 additional cases. The Department of Health then conducted additional infection control assessments and additional point prevalence surveys until 2 follow-up surveys didn't show any additional transmission. So kind of a very aggressive and exciting way to prevent transmission that is having effects nationwide. How do we know that? A couple of things, a couple of ways. One, which was highlighted in the MMWR, is these data here. And what it shows on the left-hand box is what happened with a type of resistant gram-negative called ESBLs that kind of predated the CRE and was kind of the original resistant gram-negative before CRE. And as you can see, when these emerged in the 1980s and 90s, there was kind of the response as usual, and this kind of shows what's happened to those bugs between 2006 and 2015, and I think you can see there's a slight decrease there, but it's remained relatively stable. CRE, the bacteria that we've been talking about since the beginning, however, that emerged here in the United States about in 2001, had a more aggressive response, with including specific guidance in 2009 that specifically addressed and targeted these pathogens. And the good news there is that the percent of healthcare-associated infections that are caused by CRE have decreased from about 10 or 11% in 2007-8 down to about 3 or 4% in 2015. Lastly, we're able to do some kind of very sophisticated modeling to look at what this type of the effect that this type of response might have over time. And what this shows is that based on our mathematical modeling, that if we didn't do anything and we kind of let these things continue, the red line is what we would see as far as transmissions per day, and I think you can easily see that by the end of this, there's about 40 or so transmissions a day. If, however, we use this containment approach and had an intervention that was only 5% effective, so not hard to believe that that could be achieved, we can cut that number of transmissions today by about 50% to about 20, and then if an intervention shown in green is about 20% effective, we can actually cut that down to very low numbers, and again, all very achievable numbers. I want to finish up just with some thoughts about what people can do. Obviously, for this to work, it's going to take work from everybody, CDC, healthcare facilities, clinical labs, et cetera. I encourage you to look at the MMWR if you want more details, but just refreshing, just highlighting a few of the top level things that, it's important that healthcare facilities think about that these pathogens can show up at your door and think about ways to address them. It's important to work with the health department to make sure that you're sending the isolates that are important to the health department for testing, and that you're working with them to ensure that infection control interventions are in place when they're identified. It's important to remember that these patients need to be put in the appropriate precautions when identified. It's important to communicate the status of these patients when they're transferred to a higher or lower level of care. And it's important to also look for these patients when they first the patients at higher risk when they first show up at your facility, and most often that's patients who have had recent travel or health care outside the United States. So thanks for your attention, and I'll hand it back to Catherine.